All right, good afternoon, everybody. Thank you for joining us for this afternoon's Professional Education Quickenar, our COVID-19 event on Wednesday evenings. My name is Matt McDonough. I am with the ESRD NCC, and on behalf of the NCC, I want to thank you for joining us for this afternoon for this informational, professional, educational Quickenar on COVID-19. These 30 minutes events are held in partnership with CMS. They are weekly again. And this provider series focuses on how subject matter experts from around the country or the organizations they're with are coping with the COVID-19 situation. Before we begin, I want to remind you that this call is being recorded, and we will be posting the recording to our NCC COVID Quickenar page, usually within 72 hours. So let's take a look at our agenda. We'll talk a little bit about what this call is about, although I think we just did that. We'll introduce today's speaker. As you just heard, we have Dr. Alan Kliger with us, and he may be joined by Dr. Jeff Silbersweig. They are the co-chairs from the American Society of Nephrology, and their topic today is going to be ASN's COVID-19 Response. Now, during today's event, we encourage you at any minute, or when the urge strikes you, if you will, to submit your questions to us using the Q&A panel or the chat panel. Those are available from your WebEx menu. As time and our event today allows, we will answer as many questions as we can before the conclusion of our event. So again, what is this call about? It's a chance to hear from stakeholders and peers who are adapting to COVID-19. And the ultimate goal of this call is to provide some real-world strategies for you or your facility to put into use or to learn something to help you in your day-to-day operations. So it's my pleasure now to introduce Dr. Alan Kliger, who's the Clinical Professor of Medicine at the Yale University School of Medicine and Vice President and Chief Quality Officer of the Yale New Haven Health System. I served formerly as a Senior Vice President, Chief Medical Officer, the Hospital of St. Raphael in New Haven, Connecticut. Also the past President of the Renal Physicians Association, and he serves in its Quality, Safety, and Accountability Committee. He's also past President of the Forum of ESRD Networks, and Dr. Kliger is Chairman of the Steering Committee for the National Institutes of Health Frequent Hemodialysis Study, which is a national prospective randomized study of in-center daily and home nocturnal hemodialysis. It's my pleasure to turn things over to Dr. Kliger.
Hi, everybody. I have 11 minutes to tell you everything that I know about COVID-19 and dialysis. Let's go to the next slide. I just want to outline sort of at a 10,000-foot level the cataclysm that has hit us in the renal community with COVID-19 and how the ASN in designated a COVID-19 response group has been able to affect practice in the outpatient and the inpatient arenas and affect policy in communication with the government and with suppliers. So this COVID-19 response team was just formed in March as the pandemic became clear and as we started to see evidence of this infection affecting everybody, but including our patients. And it became really clear to us pretty quickly that dialysis patients are particularly prone, number one, to develop COVID-19, and number two, if affected by COVID-19, to have serious side effects of that disease. The reason that they're so likely, number one, to get infected is that unlike the rest of us, dialysis patients can't do social distancing. If they're coming in for outpatient hemodialysis, by definition, they are in relatively close proximity to other patients, and with all of us that know very well what the inside of a hemodialysis unit looks like, even with efforts to keep them 6 feet apart and to wear masks and to do all of the other protective equipment, the likelihood of exposure in that setting is far higher than it is in almost any other, except perhaps for nursing homes. The second is that our patients are particularly prone because of comorbid conditions of hypertension, particularly diabetes. Obesity has been named as a risk factor, and obviously age, all of which are significant problems. So as we examined the problem of the spread of this infection, it became clear to us that we needed to look at 4 areas of concern. So the first is we had a group of doctors from around the country and nurses involved in in-center hemodialysis in a committee that worked with the CDC and worked hard to come up with best recommended practices in that setting. The second is it also became clear that the effects of COVID-19 on patients with previously normal kidney function was very substantial, and that in patients who were so sick with COVID-19 they needed to be hospitalized, who ended up in the intensive care unit on ventilators. If you look at that subpopulation, anywhere in different institutions, anywhere between 20% and 70% of those patients in ICUs and ventilators had acute kidney failure and required CRRT or dialysis treatment in order to survive. So we had a subcommittee working hard on the acute dialysis work. Third, we have a population of patients at home on dialysis. And while they don't have the social distancing problems, they do have particular issues of having deliveries done and getting their equipment properly to them and being able to be followed even though they don't come into center because of the problems of transportation and exposure. And so we had a home dialysis subcommittee working hard on that. And then finally, a group working on transplant patients. What happens when transplant patients are exposed? What happens when they get COVID-19? What do you do with their immunosuppression? What does their mortality look like? How do you manage that? So 66 different physicians around the country were working in each of these areas. On the next slide, you will see that we did a lot of work in educating our whole community. I hope many of you were able to catch the webinars that we ended up sponsoring once a week since March. We didn't intend initially to do that. We started with a first informational webinar. 2,600 people signed up for that webinar that talked about what's the best practice that CDC is recommending in outpatient dialysis. And the need was so great that we ended up giving weekly webinars in each of the areas you see on this slide. We had a total of 40,000 people who attended these webinars or who downloaded the webinars from our website thereafter. So there's been a very large effort to educate the kidney community on best practices, limitations, what we know, what we don't know. Also, I want to mention here that we have sponsored a group of weekly calls with the dialysis company chief medical officers. And that's been attended by around 20 chief medical officers from around the country, from all of the different companies, where they have a chance to share experience, share questions, ask each other and ask us for information. The CDC has representation that speaks there as well. So we've really been able to bring some of the dialysis the people who run dialysis in, and they've worked very hard and collaboratively. Next slide. What you see here is that in those efforts, we've been able to, on the left side, have a whole series of peer-reviewed publications in the renal literature on what this looks like, what the mortalities have looked like, what best practices need to look like, and what you do in the outpatient unit, in the inpatient unit, and at home, and among transplant patients. And on the right side, you'll see that the popular press has been very interested in what we're doing, with several stories quoting us in the New York Times, in the Washington Post, in ProPublica, in a whole series of publications that you can see there. In addition, several of us have had the opportunity to get interviewed on television. I had an opportunity to get a long interview on the PBS NewsHour a few weeks ago. So there's been lots of exposure to what this has meant, what kidney disease role kidney disease plays here, and why our patients are particularly prone to infection and to mortality, and what we need to do about that. Next slide. ASN has established a COVID-19 web page that allows us to have resource information, publications, other information that's been culled from the CDC and from our other partners. We also have an opportunity here to show our connections with ASPR and HHS, and now with the Department of Defense, as we've been able to talk to the government. And we've been able to talk to other organizations like the National Kidney Foundation and a variety of professional organizations, the emergency room doctors, to establish together what the best plan and policy is of caring for our patients as they come into the emergency room, and how do we make sure that we get enough equipment and fluids to hospitals when they run short in places like New York that had a huge run-up in the pandemic. Next slide. All right, so that is my brief prepared talk. I wanted specifically to make that short and give you an opportunity to see if there are specific things that you want to know about or anything that I can answer about the work that we've been doing.
Oh, thank you, Dr. Kliger. We've actually got a number of attendees online, and this is the part where we always remind you, if you do have a question for Dr. Kliger, please go ahead and submit them. Use that chat panel or the Q&A panel. He's been kind enough to leave us quite a bit of time, and we hope to give everybody a chance to get their questions answered. I personally have a question that I'd like to start with, if that's okay with you. Obviously, with such a fast-moving disease, and we're in such a dynamic environment where we went from 0 to 60, and it feels like we're going back towards 0, the challenges of communicating and learning and staying ahead of the curve are pretty evident there. I did have a chance to watch your PBS Frontline interview a little bit, and I know you were leading off with about how the disease, you're learning new things about the disease, what it meant for kidney patients, et cetera. So as you learned those things, and you're working with such a big group of doctors and large dialysis organizations and whatnot, how did you best synthesize that information and get that out to people, you know, in an efficient and effective way?
Yeah, so let me give you an anecdote and explain how that's hard to do and how challenging that is. So here's the anecdote. When this first started, our very first webinar was meant to take the best known evidence-based practice guidance that CDC has provided for us and to help inform what outpatient dialysis units should be doing. And in that very first webinar, we quoted the CDC as saying that, that staff who are taking care of patients with this disease should be using N95 masks to maximally protect them, that surgical masks were probably nearly as effective at protection, but that for staff caring for patients in dialysis units where there was no one with symptoms and where there was no current COVID-19, that those staff and other patients need not wear masks. And that information from CDC was based on all of their epidemiologic evidence from previous infections, from influenza, from other COVID-type viral infections. And in fact, we were pretty strong in making that recommendation, saying that if everyone was going to use masks, there would be no masks left for the in-hospital setting where they really would be necessary to protect everybody. Well, what happened, everyone now knows. I mean, it seems like that's ancient history now. What happened is that first, the chief medical officers of the chains taking care of dialysis patients on our calls and among each other said to each other, that may be CMS's advice, but does that make any sense if our patients are coming in such close contact with each other in communities where we know that COVID-19 is being spread and perhaps is being spread with patients with no symptoms? No, I know that's best advice. That's not what we're going to do. And the chief medical officers of the large dialysis companies, as we talked about it, said to CDC, you know, we're going to be using masks. What do you guys think? And the CDC's response was, well, that's interesting. You know, we wouldn't fault you with using them, and we need to think about it and examine it. And they did examine it and thought about what's happening in the real world and on the ground. And came back, as you know, and in fact said, yeah, that's actually a really good recommendation. And furthermore, we then heard about cloth masks for everybody who was walking around. So as that evolved, what became clear is that we couldn't sort of be dogmatic, that we would make best recommendations, but with the understanding that as we're all learning, we need to be able to listen clearly to each other. And the CDC does the same thing. And as more information evolves, change and move to give what's the best care.
Thank you. That's a excellent way to put that into perspective. I do have a follow-up question based on that, though, because as we said, we're in a dynamic environment. You obviously know that, and there can be sometimes conflicting sources as we're trying to stay ahead and stay dynamic in what we're doing. Things like the stories coming out about reduced risks from non-symptomatic carriers, et cetera. So with all these things floating around, how are you filtering your messaging? We all know here communication, consistent communication, so important. How are we filtering out what's bad and remaining what's good when everything's still changing?
So the first answer to that is we try to be as transparent as we can about what we know and what we don't know. Because often when there is conflicting information, it's not because one is right and one is wrong, because each position takes a different interpretation of what we do or don't know. And so let me give you another example of what we're struggling with that right now.
Sure.
How do you know when it's safe for somebody who's had COVID-19 to come back to the dialysis unit? Often when patients are very sick and they need to be hospitalized, we initially make the diagnosis by doing reverse transcriptase PCR testing. That's the virus testing that everybody knows about with those swabs that tickle your brain through. And those tests are very sensitive if they're collected properly. And so the CDC said, well, one thing you can do is to have a series of 2 of those that become negative 24 hours apart. Then the patient's not infected anymore and they can come back. All right. So it turns out that in the experience of one of the large chains, as this was done with now 1,500 patients, dialysis patients, that have been ready to leave the hospital and come back to this chain across the country, it turns out that between 15 and 20% of those people coming back remain persistently positive by that viral testing. Well, what does that mean? Does that mean they still have virus? It's not likely, because when viral cultures have been done in the limited number of cases they've been done, it looks like the virus is almost surely gone and can't be spread 9 to 10 days after the start of infection when somebody recovers. But these tests have remained positive for sometimes weeks, and in some cases even months. And so everybody wants to know, is it safe to have a patient come back to the unit if we test them with a PCR test and they're positive, or they're negative and then become positive again? What the hell does that mean? And the answer is, nobody knows the answer to that yet. And we're still struggling to figure that out. So when there appears to be conflicting or uncertain information, I think we do what the responsible thing is, which is you say, I don't know what it means. In the setting of not knowing, it's always best to err on the side of being conservative, and people then talk about the best approach.
Absolutely. Absolutely. A question just came in that I'd like to pose to you. Actually, 2 questions. I'll kind of combine them a little bit. Now that we're seeing communities starting to open up, are you expecting or a rise in COVID patients among dialysis patients? And tangential to that, with the state starting to open up now and that risk we just talked about, how are you seeing that affecting the dialysis units in the organizations that you're talking to, or has it yet?
Yeah, so I have 2 ways of answering. It's a great question. 2 ways to answer that. The first is, if you look at the epicenter, if you look at New York, we now have some epidemiologic studies of the general population in New York, where, as everybody knows, the case rate has been falling and falling and falling, and everybody's saying, let us out, let us socially mingle, let us go to the beaches together. This damn thing looks like it's over. If you do the epidemiologic studies of the general population in New York, how many of them have antibodies showing that they've had the disease and are likely, no one knows for sure, but likely immune to it? What would you guess in a place like New York? Well, some people would say, for example, in influenza, when we stop worrying about it, 50, 60, even 70% of people have antibodies showing that either they've been immunized or they have had exposure to the disease. 2 weeks ago in New York, or 10 days ago in New York, when this general population was examined, 17% of the general population have immunity. Well, that means that 83% of the population is still just as susceptible to this infection as they were in February. 83% are just as susceptible. And so given the opportunity for that virus to spread again, and that of course happens when social separation stops, since we have no immunization available right now, no passive immunization with injections. There's no question in any of the experts' minds that when you see groups gathering together and not carefully social distancing or using masks, there will be an increase in spread. Absolutely no question about that. But let me tell you what it means for dialysis units, because we have two lines of evidence that are coming out now. Number one is if we look at places like Seattle, which was one of the first places where this was described in their patients in dialysis units. When we look at the evidence in Seattle dialysis units and Northwest Kidney Centers, there's very, very little evidence that there has been spread of infection in the dialysis unit themselves. Very, very little evidence that any patient has caught this bug in the dialysis unit. And it well may be that with all of the precautions that we've taken of screening, of separating, and of using appropriate, protective equipment, et cetera, that's been successful. On the other hand, there are certain specific dialysis units that now have been reported in the literature where there has indeed been significant horizontal spread. There are several publications that are under review right now that show that there are specific dialysis units where you can identify who the index case was. In some cases it was staff, in another case it was a patient, but where the spread happened horizontally across a whole shift of dialysis patients. And so the right answer is it's likely that the current work we're doing to protect patients is working in preventing spread in the dialysis unit, but that if all of those steps are not taken, it can spread like wildfire. And that's the way we have to think about it and look at it.
No, thank you for that. Thank you for that. One question just came in. I'm thinking this came in from someone who's affiliated with a larger organization. Besides the weekly calls that you're having with organization CMOs, amongst yourselves as part of that 66-member ASN team and the ASN as a whole, how are you disseminating and receiving information updates among your membership?
Oh, man. Well, among the general membership, it's really with these weekly webinars where as I say, we've reached over 40,000 people. So that's been probably our most effective vehicle. Also, I was on a Journal Club Twitter chat. Now, I hardly heard of Twitter before this. I've never been a Twitterite, but was asked to join a Twitter conference call that lots of other nephrologists were on. This was about a month ago. And man, huge exposure, questions, answers, things happening back and forth. A very, very effective Twitter chat that happened. So we're doing that. But among our group of 60 or 70 doctors who each in turn are leaders in their communities, we're meeting several times weekly. We have a general meeting of all of us once a week. We have meetings of each of the subcommittees working in addition to that, an additional once a week. And then we have projects like the webinars that we're working on in which we're meeting. So I can tell you, for me, for example, I have an incredible part of my week every week now is devoted to this work.
And scanning the list of physicians, I noticed you're a very geographically diverse group. So you've got a lot of us covered with those communications.
Yeah, I mean, by intention, obviously. Yeah.
Yep. One final question, and this is a little more of a personal reflection question. With all of these actions that you've been providing information and collaborating, and as we're moving forward into, I guess, what we're going to start calling the new normal with COVID, what is the greatest lesson that you, as a physician, have learned in this new environment?
Honestly, to be humble. I mean, I think the best personal thing I learned is this. I tend personally to feel somewhat dogmatic. When I read and understand what best evidence is, and when there's clear evidence behind something, I become like an apostle. I think this is the way it ought to be, and everybody has to follow best evidence. And that's in general the way, whether I've liked it or not, when I look at myself, that's kind of what I have done. And I must say, the personal lesson I've learned from this is that nobody knows all the answers now. And even among people that know some of the answers, those answers move and change. And some things that sound crazy when you first talk about them turn out to be dogma a month later. So my personal lesson is to be humble and to listen carefully to what people are saying and look carefully what the evidence is. I no longer blindly say, listen, if CDC says it, this is what I do, because I've learned that is not always the case. And I've also learned that sometimes people with out of left field ideas turn out to be, not too bad. Ideas turn out to be bad. So honestly, that's my biggest personal lesson in this.
Thank you. We actually did have two questions just sneak in, and they're related to each other. And so if I may ask you one more, a lot of patients are having mask issues, not comfortable wearing masks, not comfortable with the type of mask they're wearing. Today, as with your recommendations as they exist today, what types of masks should they be wearing? Cloth okay? Is surgical recommended? And how long do you foresee that being part of the new normal, so to speak?
Yeah. Well, I don't know the answer. Talking about transparency. So I don't know the definitive answer, but let me tell you what I do know. What I do know, first of all, is that there's a hierarchy of what masks do. So, PAPRs or the N95s, which are the stuff that is used by staff in the hospital taking care of known COVID cases, those are the most protective for the person using it. I know that standard surgical masks, the kind that are tied behind your head, not the looped behind your ear type, I know that the standard surgical masks are probably almost as effective as the N95s are in most circumstances. And then down the hierarchy, the looped paper masks are good, but not as good as the others. And that cloth masks are good not only in protecting people around you from you, which is probably the biggest value. If you happen to cough or sing or breathe hard, which are the things that increase the spread of virus if you happen to have it and don't know it, those cloth masks really protect people around you, substantially cut down on the droplets that go outside of you, but even may be valuable to a modest extent in protecting you from people around you. So the answer really is masks of some kind are better than no masks, and that in relatively low-risk areas like dialysis units where there are no identified infected patients, probably any of those masks, and probably including cloth masks, are probably a not unreasonable solution. Now, I know a lot of our patients can't stand wearing the masks, and our nurses walk around all the time saying, please put your mask back on. It doesn't help if it's around your chin or around your neck. So there's no question but that that takes some doing, and that I believe this new normal will go on until we have herd immunity. Herd immunity means that instead of 17% immunized people like in New York right now, we have 50 or 60% immunized people. Until that happens, I think we're going to be doing just what we're doing now.
Well, Dr. Kliger, thank you so much for your time today. It has been an extremely informative chat. I certainly appreciate your time, and I know our audience does as well. And we just really want to thank you for being here today.
And thank you all very much. Thanks.
You're very welcome. Take care, sir.
Bye-bye.
Well, let's go ahead and wrap up today. Let's start by talking about the kidneyhub.org. This is a new resource for patient and professionals that's designed to be viewed on a mobile-friendly device whether it's a smartphone or a tablet. We've got links to important resources that you see on the screen. There's also some new things being added, such as links to the patient grant library, and there's also links to new features on the transplant page, such as transplant videos, etc. So we're adding things all the time. I encourage you to go out if you haven't yet and check it out and see what is out there that may interest you. Our next COVID-19 events will be next week. We'll start with our patient event on June 16th. That's at 5 p.m. Eastern Time, and our provider event is on June 17th at 5 p.m. Both of those events will be joined by representatives from the Centers for Disease Control. We'll be sharing information from what they've been doing and the advice that they've been working to disseminate, as we just heard some of that. So if you'd like to join us for those events, please visit www.kidneycovidinfocenter.com for more information on each of the event topics and to register for those events. On behalf of the NCC, I would like to thank you for your attendance today. We do have additional COVID-19 resources that you can access. The links to those are on the page. These slides will also be published in conjunction with the recording of this event within 48 hours or so, and you'll be able to access these links there as well. So again, thank you for your time today. Thank you, Dr. Kliger, and we hope to see all of you on a future NCC Quick and R. Thanks, and have a great evening.